This program is brought to you by Emory University.
All right. Well, we have to talk about SVT in adults and other neurocomplex tachycardias. Um, this is the makeup for SVT. 9 out of 10 patients that you see that have true neurocomplex tachycardia, there's some sort of reentrant mechanism. So it's important to understand the electrophysiology of them. 10% are, of course, not reentrant. We get a selection bias here because we have a lot of end-stage heart failure patients and other sick patients. So I think our non-reentrant arrhythmias are a little higher here, but this is kind of all comers. Of all SVT, AV node reentry you have to know. And so we're going to spend some time with the animations today to make sure you understand the physiology of AV NRT, why it happens, why it's so common and how you fix it. Because AV NRT is really the big one. So if you had to guess on your boards that it's just a neurocomplex tachycardia and you can't see P waves, pick AV NRT. 30% are orthodromic reciprocating tachycardias using accessory pathways, and then the other 10% are ATACs. When you think about SVTs, you can divide it according to mechanism. You can think of, okay, a spot of cells somewhere in the heart for whatever reason, hyperthyroidism, sepsis, or just scarring that causes triggered activity. So that's a little pulsing in the atrium somewhere. This includes ATAC, junctional ectopic tachycardia, and sinus tach. The micro-reentrant arrhythmias use little scars. So these are basically similar to VT circuits within the atrium or elsewhere. And that includes some atrial tachycardias. These are the patients that have prior heart surgery or valve surgery repair that have ATACs. The macro-reentrant tachycardias include those that rotate around entire chambers, so the size of the reentrant arrhythmia is bigger, or they're using numerous chambers like the A and B. And this, of course, includes all atrial flutters, AV node reentry, and AV reentry, which is accessory pathways or accessory connections between the A and B. Incidentally, does anybody know what this MRI shows? I was just looking at this morning. Jeez. Yeah, the imaging you guys have down. Here's how we classify it in EP world, and this is the language that you need to speak. You need to speak in terms of RP relationship. The RP relationship, not the PR relationship. And this is more due to the fact that these are reentrant arrhythmias, and so the P wave follows the QRS a lot of times as opposed to the opposite. So we think of things in RP terms. So long RP tachycardias, i.e. short PR tachycardias, include things like sinus tach, ATAC, atypical node, AV node reentry, AVRT with slow retrograde conduction like PJRT, which we may touch on today. The short RP tachycardias, the biggest short RP tachycardia is typical AV node reentry. But you can also have short RP tachycardias from atrial tach or sinus tach that has a long PR interval, so that this P is driving this QRS, and this will fool you. This will be a short RP tachycardia, but it really is driven by the A. And of course, AV reciprocating tachycardia using accessory pathway falls in this category, as does junctional tachycardia. But when you have a patient that's you're down in the ER with tachycardia, here's the stepwise approach. Don't look at the tele, get a 12 lead of it, okay? They're not gonna die. Get a 12 lead, you'll be able to see the P waves. Here's the tachycardia. Now, if you just had a tele, you get something like this where you can't tell anything about where the P wave is. But if you get the 12 lead, you'll get clues, and you can see the P waves here, and this is really important, so you know this patient has a short RP tachycardia. With the and you tell the 12 lead person to stay put, tell him not to leave, then get your adenosine. Push the adenosine. The next thing after you look at the RP relationship is get the adenosine and have them continued to be hooked up to the 12 lead. So which rhythms respond or terminate, I should say, to adenosine? Well, about a third of atrial tachycardias terminate with adenosine. These are the non-micro reentrant atrial tachycardias, the ones that are focal or abnormally automatic. Junctional ectopic response to adenosine. Anything that depends on the AV node, of course, will terminate with adenosine. AV node reentry most often terminates. AV reentry will terminate because it needs the AV node as part of the limb. How do you know if they felt the adenosine? They will always feel something, and I'll look on the 12 lead as you run the continuous rhythm strip. You'll see this huge oscillation in the rhythm, and that's when they go, they feel terrible. If they don't feel that funny feeling, they didn't get the adenosine. That means you didn't flush it right, or the patient didn't flush it right. Look carefully at the termination. Look carefully at the termination. This one's hard if I just showed you a 12 lead, but here I cheated. I show you catheters in the atrium. And I can tell you that this patient does not have an automatic ATAC. I'll bet $100 the patient doesn't have an automatic ATAC. Why do I say that? How does it end? Does it end with the QRS or does it end with the P wave? It ends with a P. If this, and there are certainly adenosine responsive ATACs, but if your tachycardia ends with the P wave, that would be saying, okay, the ATAC, because the A's are driving the show. You're saying that the atrial tachycardia spontaneously terminated at the exact same time you had all of a sudden had AV block. That doesn't make sense. That would be too coincidental. So if it ends with a P wave, you probably are dealing with an AV node reentry or AV reentry. Does that make sense? If it ends with a P wave, it's probably not an ATAC. It would be too coincidental to have AV block and termination at the same time. Because what's driving the show in ATACs are the P waves. So if the P wave were here, you'd expect the QRS to follow. This patient has AVRT because the subsequent sinus beat you see has delta wave. If you have AV block and persistence of P waves, boom, 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 here's the adenosine. This suggests that the atrium is driving the show. So this is an atrial tachycardia. If you have termination like this case, you know it's an atrial tachycardia. If you had just persistence of the atrial arrhythmia and the AV block happened, then it just picked right up and you're back off to the races after the adenosine wore off, that's more likely an atrial flutter or a macro reentrant or micro reentrant, some scar reentrant atrial arrhythmia, because those do not terminate with adenosine. They'll respond, you'll have AV blocks, so you'll unmask the flutter waves, but then once the adenosine wears off, you'll be back off to the races. Okay? So adenosine is important. I usually use 6, but I'm very, yesterday we were in a case and we wanted to make sure the pathway was gone. We just flushed 12 right in the sheath, right in the left atrium. Don't be shy, and really flush it right. The ER nurses are good at it, but floor nurses, sometimes you have to do it. You got to watch them. So here's a 23-year-old with anxiety. Her mom brought her in because her Xanax wasn't working. Here's her 12 lead. This is a very common story, especially young women with SVT get labeled as panic attacks, and they just think it's panic attacks. And they last usually 5 minutes, and then it pops out, and so they think, okay, I'm fine. But this one didn't break. Here's the 12 lead. It's a narrow complex tachycardia. Here's what happens with the adenosine. Boom, it breaks. And frequently with the adenosine, you'll see a lot of artifact. You won't be able to tell what's going on. All you'll be able to say is, okay, it's broken. So what are you thinking? What are you excluding? Well, I'm excluding atrial flutter and micro-reentrant ATAC, but everything else is on the list. Can you see P waves? I don't know, maybe, but that's why the resting 12 lead after the adenosine is so important. So here's your 12 lead after the adenosine. So let's look at that. Here's V1 after adenosine, a normal sinus rhythm. Here's tachycardia. So that this pseudo R prime that everyone should be trained to look at is a clue. So you don't have an R prime here, you have a pseudo R prime here. This is not an R prime, that's why we call it pseudo, because it's the P wave. So this is a short RP tachycardia, and not only is it short, it's incredibly short. It's so short that you can barely tell. So they're right on top of each other. So this is what? Typical AV node reentry. I hate to beat this if you know this already, but it's critically important, and I want you to understand. 30% of us are born with dual AV nodal physiology. Okay? This Blaufus, I think, is a great thing. The fast pathway is how you conduct normally. The fast pathway conducts rapidly, but like a fast boat, it has a long refractory period. It's more prone to block ectopy. It's a long ERP. The slow pathway conducts slowly, but because it leaves a slow wake, it's got a short refractory period. So in sinus rhythm, you get fast, and then the slow just runs into it. Boom. No big deal. But everybody has ectopy. When you have a diarrheal illness, you're febrile. Someone has a PAC. So if you have a PAC that's critically timed, boom, early, the fast pathway, because it's refractory, will block. The slow pathway is not. It'll conduct. And because it takes so long, once it gets up to the AV node, the fast pathway is ready to go, and then you're off to the races. So you have unidirectional antegrade block in the fast. The slowly conducts up. Once it runs into the node, the fast is ready to go, so it's going to conduct backwards, and this is the mechanism of AV node reentry. Does this make sense? The reason it's a short RP tachycardia is because it's the fast pathway. So the P waves can, boom, just as quick as the His-Purkinje system. So they're happening the same time. And so what we do for the majority of SVT ablations is stick our ablation catheter up here and burn that slow. We used to burn the fast, but the AV block incidence is too high. So think about atypical AV node reentry. Atypical AV node reentry is the exact opposite phenomenon. It's conducting down the fast, depolarizes the QRS, then it takes a long time for the slow pathway to conduct a retrograde P. That's why your RP is long. Make sense? Look at these Blaufus. If this doesn't make sense, it should. Look at them, spend some time on the movies. They're helpful. So here's atypical AV NRT. Down the fast, so the QRS happens, then retrograde up the slow. The RP is long. It's an upside down P wave right before the next QRS. How is it fixed? The exact same way we fix the typical. We ablate the slow pathway. How do I know this is atypical AV NRT? Well, look at the P wave vector. It's pointing, it's going from the person's head, foot to their head. It's northward, right? It's opposing the inferior leads, backwards. And it's positive, another clue is it's positive in AVR and AVL. When I see positivity of a P wave in AVR and AVL, I think it's coming somewhere from the septum. So I know it's coming somewhere down low in the atrium and the septum, which would be right from the slow pathway, the bottom part of the AV node. So this is a classic EKG for atypical AVNRT. So here's that reentrant loop, here's the coronary sinus, and what we ablate is the slow. All right, so this is a person with palpitations and chest pain. It's a narrow complex tachycardia around 200. By the way, chest pain. Almost all patients with SVTs over 170 have angina symptoms. And it can be very classic. That doesn't, please don't cath everybody, especially like a 35-year-old woman. They can have angina. That's an acceptable thing. They can also have non-specific ST changes, so it's not a reason to cath or stress the patient. Irradiate, you know, a 32-year-old with no risk factors. So does anybody see P waves? I don't know. I can't really, and that's okay. We gave adenosine, and this is her EKG after. So does that help you at all? How so? So you have delta waves. So this is probably the smoking gun. So this is WPW. And so this tachycardia is what is called what? What do you call it? Antidromic? Orthodromic? Anybody? Bueller? Orthodromic. Orthodromic. It's right. It's going down the AV node. It's depolarizing the right way, down the AV node. So orthodromic AV reciprocating tachycardia. Utilizing this pathway in the opposite direction. This is a lot simpler. So if you have a pathway, many of these will not conduct antegrade. Okay, so you won't have a delta. You can certainly have a pathway, but not see a delta wave. So don't exclude a pathway just because they have don't have a delta wave. But if they are manifest, your QRS will be a fusion of the pathway depolarizing the ventricle from some bizarre place, and these can be anywhere except the atriomitral curtain, and the natural conduction system. The right-sided pathways, because they're closer to the sinus node, will tend to have more overt pre-excitation, obvious deltas, and the far-away pathways, the left free walls, will tend to have less or more subtle pre-excitation. But there'll be fusion, and the way we tell where the pathway is, or the way we sort of triangulate, is look at the vector of the delta wave, which is another talk that I give every fellow that rotates with us in EP. We should be able to tell where the pathway is based on the 12 lead. So here's normal, boom, delta wave, everything's hunky-dory. Then a PAC happens, rendering this pathway refractory. This conducts slower because it's a decremental AV node properties, depolarizes the ventricle. By the time it reaches the pathway, it conducts backwards, and so we have a narrow complex tachycardia. There's nothing special about accessory pathways. They're just myocardium, little strips, remnants, leftovers from in utero. They're supposed to involute. All of us had WPW in utero. It's just the fibrous annulus is supposed to kill them all except for the AV node. These are leftover strips, and these will conduct rapidly, so it'll be a short RP tachycardia. The difference between typical AV node reentry and AV reentry, AVRT, is that this short RP tachycardia, it's not that short. It's not right on top of each other. You usually can see the P wave a little better. It's in the ST segment. So if you see a narrow complex short RP tachycardia where the P wave is in the ST segment, think it's AVRT, orthodromic AVRT. Sorry, they won't play in my slides, so I have to switch back and forth. So you guys had this question on your boards or your in-service yesterday. So what is the drug of choice for this rhythm? Procainamide or ibutylide is reasonable. This is pre-excited AFib. So this is atrial fibrillation conducting rapidly down a pathway. And this is what predisposes somebody to sudden death. This is why pilots and elite level athletes usually get their pathways ablated, irrespective of symptoms. The risk of sudden death is very low in WPW, but is there. So what are the drugs that are class 3 for pre-excited AFib? Any AV nodal blocker is good, and amiodarone. I disagree with the amiodarone thing, but we'll just blindly obey the gospel of these guidelines here. Amiodarone, intravenous amiodarone causes hypotension, which can lead to pediatric hemodynamic collapse. And in fact, this whole baloney about AV nodal blocker and increasing the conduction down the pathway, it's not really that. This is all from peds that just had hemodynamic collapse from acute hypotension from the drug themselves. So that's verapamil, can give acute hypotension, and IV amio can give acute hypotension. So anyway.
I do have a question about that.
Yeah.
Why would giving a beta blocker cause it to go faster down the accessory pathway? Like it's already going down the accessory
Yeah,
pathway, right?
you can theoretically remove concealment. So if some of it's going down the AV node, you can maybe get retrograde invasion in the pathway, rendering it refractory a little bit. But you're right, it's baloney. But we're not gonna. We'll just for the guidelines and the boards, just stick with what you know. But you're right. So here's a high-risk pathway. If they've had syncope, they need it ablated. If their refractory period is less than 250 milliseconds, or more importantly, if you see a patient like this, measure the interval. If these QRSs are closer than one big box, that's a malignant pathway. He needs an ablation, or she needs an ablation. There's no, don't futz around with drugs. So if they ask you about that on the boards, they need an ablation. So if the QRSs are less than 250, 220, really they'll show you one where it's closer than one little box, 200. Ablation is the right answer. Sudden death risk is usually very low. So AVRT, orthodromic, down the AV node, up the accessory pathway. The P's, the retrograde P's, will be usually in the ST segment. So yes, it is a short RP tachycardia, meaning the P wave is closer to the preceding QRS as opposed to the following QRS. But it's not as short as typical AVNRT. Okay. Other clues that you have AVRT, and it's really AVRT, is if you have QRS alternans. Don't ask us why, because we argue about it in EP why that happens. But if you have QRS alternans, that's a clue that it's AVRT. If you have aberration, just because you have aberration, they're more likely to have a pathway. If you see this, now this is tachycardia stretched out in like an EP likes it at 200 millimeters per second. And you have widening of the QRS, which results in prolongation of the RP. You see that? So this is the A. RP is short and narrow. And then when you have bundle branch, you have prolongation. What's that sign called? Anybody? Eponym? Kummel. Kummel's sign. So this is where aberration causes change in the tachycardia. So what's happening here? You have a left bundle aberration, so it's going down the AV node, but because it's so fast, the left bundle aberrates. It's a left bundle block. So you go down the right bundle. It has to go transeptally, not through the His-Purkinje system. Then it goes all the way around the left ventricle to get to the retrograde pathway. It takes longer because of the bundle branch block. So if you have prolongation, that tells you, with the left bundle, you say, aha, this is a retrograde conduction over accessory pathway, and it's somewhere on the left. It's somewhere ipsilateral to the side of the bundle branch block. This is Kumel's sign. So if you see aberration, just because there's aberration, because of other factors we won't discuss, it's more likely to be accessory pathway mediated. But B, look at the RP relationship, because if it changes, you will look super smart, because you'll know the mechanism of the tachycardia and where the pathway is located. So you're going to already know that we're going to have to do a transeptal puncture to map the pathway. So if you had right bundle aberration and it prolonged the RP and prolonged the tachycardia, that means it's a right-sided accessory pathway. Anhydromic tachycardia is very rare. It usually requires numerous pathways. If you see something that looks like VT and passes all the morphology criteria for VT, but is adenosine responsive, and there's not a real good reason for the patient to have VT, think about anhydromic tachycardia. Because the input, how the ventricle is being depolarized, is just some random place near the annulus, wherever the pathway is. So this passes all the morphology criteria for VT. Okay, maybe on the boards, this is why we'll talk about it. This is a case that I've had. So this is a tachycardia that's minimal, like 110. And the question stem will be, young lady, persistent tachycardia, tachymyopathy. So she won't really know she's in tachycardia, but she's been in 110 for God knows how long. And it'll show you a 12 lead of a long RP tachycardia, and the P wave vector will be upside down, so it'll be negative in AVF 2-3. It'll be positive in AVR, AVL. So this would look similar to what? What tachycardia we talk about? Long RP, upside down P waves. Right, so I heard atypical AVNRT. So yes, it will look like atypical AVNRT, but this special pathway is a slowly conducting decremental accessory pathway that is pretty rare. It's called PJRT. PJRT, permanent form of junctional reciprocating tachycardia. That doesn't matter. It's an orthodromic AVRT using a weird, slowly conducting concealed pathway. The point I want to make is that if you ever have somebody or a question, and they do put this on, it'll be a tachymyopathy with a slowish tachycardia, and it's incessant. PJRT. All the rules apply. I mean, it's still, we look for the pathway, it's going down the AV node and up the pathway. It's just that that pathway is very slowly conducted. This is the other special pathway that hopefully I've never seen it asked on the general boards. This is a patient with a left bundle branch block tachycardia. This is an accessory pathway near the somewhere on the right free wall, where the patient was born with duplication of the AV node. This is called a Maheim fiber. It only conducts antegrade. It only conducts from the A to the V. So it goes down this weird pathway and then back up the AV node. I don't know if it's important. All right. 66-year-old, sudden onset regular tachycardic palpitations. Short RP? No, it's a long RP. So what's the most likely diagnosis here? If you had to bet? Atypical AV NRT is on the list. He's old. V1 is positive. So sure, it's upside down. AVL actually is biphasic. It's upside down, but V1's positive. So this is probably nothing cool. It's probably not atypical AV node reentry. It's probably just a left atrial tachycardia. ATACs emanate from little spots. It's hard to distinguish between automatic or micro reentrant, but you can tell based on prior clinical clues. If they've had congenital surgeries, it's probably micro reentrant. Those are easier to get and they're more persistent. If it's just some person with hypertensive heart disease and no prior heart issues, it's more likely to be automatic. Those are harder to map, harder to get. If it's these bursts, if they're salvos of long RP tachycardias, it's more likely an automatic atrial tachycardia. If it responds to adenosine, it's more likely a focal or automatic atrial tachycardia. These can be anywhere. In young people, they tend to be around what's called a ring of fire, in the coronary sinus up along the crista terminalis and in the subeustachian area. But in our patient population, anywhere. Okay, here's an EKG, 78-year-old, irregular rhythm. SVT. What is this? What did you say? Yeah. Why is it not fib? All right, good. I'm glad you said that, because this is a thing that burns a lot of people, and it's very important to us because flutter, you guys know, we can ablate that. That's not, and it's a 30-minute procedure. I mean, it's not a big deal. But fib is a big deal. It's a hard thing, and we stink at ablating it. Don't use sawtooth or flutter waves to diagnose atrial flutter. Because if I give a lot of patients AFib, flecainide, I will flubberize the fib. I will coarsen it up enough where it looks, if you just looked at the P waves activity, it looks like flutter. The key, the reason you know it's atrial flutter is because you know the input is regular to the ventricles. And I know the input is regular to the ventricles because although this looks at first glance irregular, it falls into discrete RR interval bends. And if you have discrete RR interval bends, you know the input to the AV node is regular. You can have multi-level block and variable conduction, but I'm telling you this RR interval is identical to this one, and these longer RR intervals are identical to this longer RR interval, okay? So it's the fact that there's a pattern, a regular pattern of the QRS that tells you it's flutter, and it's much less due to these sawtooth waves. You can get burned by that. And we see it all the time. Cardiologists, even in this fantastic Emory facility, will send some poor guy, say, we're going to cure your atrial flutter, send him to the EP lab, and it's not flutter, it's fib. And then we have to say, well, golly, Mr. Johnson, I'm sorry, you know, they didn't know how to diagnose atrial flutter, so now we got to talk about a whole different procedure for you. Remember that typical atrial flutter uses the cavo-tricuspid isthmus as the critical isthmus. It's usually counterclockwise, spinning up the septum, down the free wall, and that's what gives you this sawtooth appearance. It's easily ablated. Here's an easier flutter because the QRSs are dead regular. So there's no question here. And this is a low morbidity procedure with a high cure rate. What percentage of atrial flutter patients go on to have AFib? Yeah, 40 is a good number. So 40%, in some series it's as high as 80, so you always have to be wary that they're going to go on to have AFib, but you know, this is one SVT that we are good at fixing. Here's another flutter that's more common. So this patient is paced, so he has complete AV block, but you can see flutter waves here. What distinguishes ATAC and atrial flutter? It's purely a rate thing. It's purely a rate thing. And I don't care. You can call it ATAC. This is technically ATAC because of the rate is what is 170 beats a minute, the atrial rate. It's really semantics. But this is a flutter that we're seeing more and more of, and this is iatrogenic atrial flutter. It is not typical, is it? There's no negative sawtooth and 2-3 AVF. This is from someone that underwent an AFib ablation. And our lines that we did to try to get rid of the AFib compartmentalized it enough and caused reentrant little short scar isthmuses that can then sustain atrial flutter. These are nightmares to ablate. They're hard to ablate a lot of times. How good are we at ablating everything? Well, AVNRT and AVRT were in the high 90s. The recurrence rate is 5 to 8%. The chance of us killing your patient or giving them a pacemaker are 1 in several thousand usually. Growing complications are pretty low. Flutter, again, very curable. The ones we're not as good at are focal automatic ATs with a recurrence rate up to 27%. Junctional tacks, as you can imagine, you're burning on the AV node. This is automaticity from the AV node. Heart block incidence is high. And then atypical flutters, cure rates are probably in the 70% range. The recurrence rates can be as high as 53%. This is useful for your counseling with patients. All right, so let's play a game to end the session. And this gets back to the point of diagnosing atrial flutter versus fib, because I think any good cardiologist should be able to tell if it's flutter or fib. And again, sometimes it's hard to do it just based on the P wave activity. Remember that all mechanisms are possible in AFib. It can be abnormal automaticity, micro reentry, macro reentry. It's just that it's meandering. It changes over the temporal course. So this is a 72-year-old on 2G. What do you call it? I don't know your name. I'm sorry. Stephanie?
The R's look regular.
Mm-hmm.
It's just nodding.
Good.
Looks like there's the baseline's a little it could be A-flutter. I don't know. The baseline for the P's are a little not that clear, but
I agree. And so when you see dead regular QRSs, if you do see something this big, pseudo flutter waves this big, they should be dead regular and perfect as well. And so what you notice is it's not. So something's not right. And what you said is the baseline is junky, and it's very junky. And in fact, if you pick a lead, and we'll use limb lead 3 here, you can see that there are just sinus P waves buried in this artifact. And we get called about this probably 2-3 times a month, or a teleconsult. So this patient's on 2G, the neurofloor. This is Parkinsonian tremor and sinus rhythm. Good, you didn't get fooled. People have received anticoagulation for this, unfortunately. Remember, Parkinsonian tremor is about 4 hertz, so you'll see 4 little spikes per 60 beats per minute. 64-year-old on 5B. This is the respiratory floor. Let's just go down the list, or the row rather.
It's irregular.
Is it regularly irregular or irregularly irregular? Truly irregular.
I'd say it's regular. Like there's some are intervals and there's not.
No, and that's not fair. I mean, you really have to measure. But I see you're saying, well, this pattern here looks similar, but they're not. They're all slightly different. So it's irregularly irregular, but
SCP ways.
yeah, yeah, yeah. So this is MAT. This is the respiratory unit, and if you see clear 1 P wave for every QRS, even though it's irregularly irregular, it's MAT. So this is a fair EKG question on the boards, a fair EKG question on the in-service exams. This is not an anticoagulatable rhythm. This is treated with calcium channel blockers or magnesium. You don't have to do anything about this. But this is frequently called AFib based on a telestrip. Without the 12 lead, it's sometimes hard to see. MAT is characterized by 3 morphologies, different morphologies of P waves and different AV intervals. Good. 77-year-old homeless unresponsive male at Grady ER. Good. Sinus Brady. Very good. So he said shiver artifact, which is faster than Parkinsonian, and then the R wave, so this is hypothermia. Can you ever have AFib and a regular bradycardia? How? Sure. And the point is that you can have AV block. Yeah. Exactly. So if you have AV block, that's the one time you can have AFib and a regular QRS, but usually they'll be bradycardia. Yeah. Good. Osborne waves. So 52-year-old on 4B. So you passed, so now it's you. No, this is just AFib or not AFib. That's all we're playing. It does. It looks pretty regular. Is it truly? Is it truly regular?
Looking at like down the rhythm strip, it's not.
Good. So what do you think? Just if you had to guess, I mean, it's not. There's no Gary tricks in here. Yeah, it's AFib. And the point I want to make here is that when people are hyperadrenergic and the AV node is really slicked up, AFib at rapid rates will be regularized. And so sometimes AFib is undercalled in very rapid rates because the RR intervals, the shorter they get, the harder it is to tell if they're if it's truly irregularly irregular. But yeah, you didn't get fooled. And this is a little Ashman sequence here where there's 2 beats of right bundle aberration, but this is just plain old AFib. And remember that in very rapid AFib, it'll look regularized, and we frequently get called that this is SVT. Or some poor person gets sent here from Tifton saying, okay, SVT ablation, you're lucky, lady, you're going to be cured, and it's just rapid AFib. So don't be fooled if it's regularized AFib, it's still irregular. All right, so remember to get your EKGs, remember to use adenosine. That's the most valuable. Remember all the points we talked about, AV-NRT. Those movies are on Blaufuss, which is an old UCLA physiologist who made those pretty movies. You can get them online. Accessory pathway tachycardias may not always be evident by a delta wave. Remember that most accessory pathways are concealed. They don't conduct, Brian, this is what we were talking about yesterday, from the A to the V. They won't show delta, but they can conduct backwards, so they can predispose you to orthodromic tachycardia. Remember, AFib really is the most common SVT requiring clinical attention, and don't rely on the P waves or flutter waves or flubber waves to tell you if it's fib or flutter. Rely on your analysis of what the QRSs are doing. Thanks, that's it.
The preceding program is copyrighted by Emory University.